eliminate the waste product and patient develop azotemia. And of course, blood flow to kidney is really dangerously reduced. So renin mechanism is slightly increased or powerfully increased? Powerfully increased. So very powerful stimulation of renin, angiotensin, aldosterone axis. Not only salt and water is retained, but one of the most powerful vasoconstrictor is angiotensin 2. So patient develop hypertension. So patient is now developing hypertension. So do you think patient is getting better or worse? Worse. So now look at it. One patient who was nephrotic going to advanced stage. Initially he had heavy proteinuria, then hypoproteinemia and generalized edema. Unfortunately, underlying mechanism of injury became amplified. So inflammatory lesions develop in glomeruli. That reduces the glomerular flow. So protein losses become less, hypoproteinemia become less severe. Of course, then proteins level are better in the blood, generalized edema become less. But actually, a dangerous black triangle is appearing, a deadly triangle. What is that? Heavy damage to glomeruli. So patient is developing hematuria, especially dysmorphic RBCs and RBC cast. With that, patient is developing oliguria with azotemia and patient develop hypertension. Now it is no more nephrotic. It is no more nephrotic. Now it is nephritic. What is this thing? Nephritic syndrome. So what concept we really made? That is the damage to glomeruli, we keep on changing the face. Is that right? That very little damage and you develop albuminuria. A little more damage, you develop albuminuria with globulinuria. So non-selective proteinuria. Heavy damage, you may develop heavy selective proteinuria or heavy non-selective proteinuria, eventually precipitating in the formation of nephrotic situation. Further inflammatory lesions leading to converting nephrotic into nephritic, or patients start directly as nephritic. And then the next patient may develop more aggressive injury. What will happen? We'll talk about after the break. Right, so in the previous lecture, we were discussing about that how different degree of and different type of injury to glomeruli can produce different type of clinical presentations, right? We have discussed few clinical presentations and more I will discuss now. Let's recap a little bit that glomerular injury, the heading should be glomerular injury, right? Not one glomeruli, multiple glomeruli of course, and you can say degree of injury +1. And what was there? Yes, you will tell me the mechanism that was leading to selective protein urea, or other name for selective protein urea was albumin urea. Then we said there was second more injury, and that was leading to, yes, non-selective protein urea, but it may be subnephrotic range, right? Then further damage, heavy protein urea, which may be selective or which may be non-selective, and this will eventually lead to nephrotic syndrome because it's nephrotic range more than 3.5 grams per day ROM. Then we come to the next situation, and injury has become more severe and producing severe inflammatory lesions in glomeruli. So in this case, you have to always remember, here was a cold triangle, and this cold triangle was, a nephrotic cold triangle was heavy proteinuria with hypoproteinemia leading to generalized edema. With that, there were two things, hyperlipidemia and hyperlipiduria. Now, in very severe injury, this cold triangle will shrink and a hot triangle will form. And this hot triangle, which is more deadly situation, even though there may be some degree of proteinuria, there may be some degree of hypoproteinemia, there may be some degree of generalized edema, but the more dangerous things which will develop in nephrotic syndrome, they are high blood pressure, hypertension, oliguria with azotemia, and of course hematuria with dysmorphic RBCs and RBC cast. Is that right? Now we go to the next situation. That let's suppose there is injury which is very, very intense injury, so severe injury it really made multiple big disruptions in glomerular basement membrane. Let's suppose injury was so severe that glomerular basement membrane had big disruptions. And there is severe inflammation of the vessels ruptured. Now in this case, of course, it's easy to understand that albumin will come down, isn't it? Globulins will also come down, RBCs will also come down, RBC which are dysmorphic, and RBC cast will also come down, right? But actually, in this particular case, lot of fibrin lays down, fibrin molecules. And fibrin molecules are accumulated here. And breakdown product of fibrin molecule are very, very stimulating to the epithelial cells for the growth. Again, listen. If there is very, very severe disruptive injury, right, then a lot of fibrin come down and it break down into product which act as a growth product for epithelial cell. Plus, fibrin attract macrophages. So a lot of macrophages come from this area to this area. So local epithelial cells are proliferating. With that, a lot of macrophages are migrating to this area with very severe intense injury. And with that, of course, there are platelets there. Other macrophages are there. Mesangial cells are activated also with this injury. And all these cells producing a lot of growth factors. Your understanding? And this very concentrated growth factors present over here, all these epithelial cells will start proliferating. And within these proliferating epithelial cells, there will be a lot of macrophages which are also proliferating. And within few weeks, you will find that whole the urinary space is full of cells. Do you think now this urinary space can work well? Again, extremely severe injury, lot of growth factor, some coming from breakdown of the fibrin, some from platelet derived growth factor, some coming from the macrophages, some growth factor coming from mesangial cells. And under the influence of all these growth factors and other inflammatory cytokines, inflammatory products, there is a lot of migration of macrophages, monocytes from the vascular compartment to urinary space, plus local epithelial cells proliferate. And they make these cellular crescents. They make these cellular crescent. Some people call this situation crescent glomerulopathy or